Hello everyone, we are the Group 5 nursing team and today we will be presenting our case study on acute pulmonary embolism. In our orthopedic clinic today, we have a 32-year-old female that had an open reduction and internal fixation surgery due to an ankle fracture that she got during a skiing accident. She currently has a below-the-knee cast in place and has been on crutches for the past 8 weeks. She reports feeling short of breath easily and thinks she's been getting out of shape since the fracture. She is a receptionist, and the only medication that she's currently taking is birth control pills.
We conducted a head-to-toe assessment and our findings show that she is alert and oriented, pupils are equal, round, reactive to light, and accommodating. Her skin is warm and dry. Her lung sounds are clear with decreased air entry to the bases bilaterally. She has increased shortness of breath when ambulating and has right-sided chest pain with deep inspiration. Her jugular veins measure 3 cm at the sternal angle. Her abdomen is soft and non-tender, no flank pain noted, no difficulty voiding, and no changes in bowel habits or appetite. Her peripheral pulses are palpable at 2+. Her circulation sensation and motion to the right toe is intact. She does state that her cast has been feeling tighter since her last appointment, but otherwise she is a healthy person and does not smoke or drink alcohol. As for her vital signs, her heart rate is 110, respirations at 22 breaths per minute and regular, blood pressure is 125/78, and oxygen saturation at 96%, and her temperature is 36.5 degrees Celsius.
Her ECG shows sinus tachycardia, peaked P waves in the inferior leads, and an S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3. Based on our assessment findings, we now query that our patient is exhibiting signs of impaired gas exchange related to decreased lung perfusion caused by a pulmonary embolus secondary to a DVT. And here we will explain why. Starting with DVT, which stands for deep vein thrombosis. There are 3 factors that are critically important in the development of a DVT, and these elements are known as the Virchow's triad. The first factor begins with endothelial damage. This refers to the damage of the endothelial lining of the vein related to direct or indirect injury. In this case, our patient had an ankle fracture.
Such injuries initiate the coagulation cascade, which increases the risk of developing a thrombus, which is a blood clot that is inside of the vein. The second element of Virchow's triad is venous stasis. Venous stasis occurs in long periods of immobility. This would transpire from both her job as a receptionist and less time ambulating due to the ankle fracture. The third triad factor is hypercoagulability. Being on birth control pills, our patient is at an increased risk of coagulation. Estrogen therapy has been associated with increased levels of plasma circulating procoagulant factors, for example fibrinogen, prothrombin, factors 7, 8, and 10, decreased procoagulant factor 5, and decreased plasma levels of naturally occurring inhibitors of hemostasis, for example, antithrombin and tissue factor pathway inhibitor.
Ultimately, our patient exhibits all 3 factors of Virchow's triad and is at a high risk for thrombus development. The common signs and symptoms of lower leg DVT are unilateral leg pain, erythema, and edema. In this case, our patient feels as though her cast is shrinking. This could be indicative of swelling or edema. One of the complications that can occur with DVTs is called a pulmonary embolism. When a thrombus is within one of the deep veins, this clot can break off and migrate up into the right side of the heart, into the lungs. The common signs and symptoms of pulmonary embolisms are chest pain, dyspnea, increased respiration rate, pain on inspiration, hypoxemia, and tachycardia to compensate for decreased oxygenation. If you remember, in our initial assessment, our patient has increased shortness of breath when ambulating and has right-sided chest pain with deep inspiration. She is tachycardic with respirations at 22 and oxygen saturations at 96%.
all of which led us to believe that she was exhibiting signs of a pulmonary embolism. When the lungs have an occlusion with the artery, this impedes blood flow to the rest of the affected artery, causing impaired gas exchange, leading to hypoxemia, hemodynamic collapse, and an increased risk of mortality. To prevent this progression, we will bring you to our planning phase. To further assess for a pulmonary embolism, we plan to utilize Geneva's scoring system. The system is based on the patient's history and physical exam. The scoring places them into low, intermediate, and high risk. An intermediate to high risk would suggest additional screening. Arterial blood gases may also be used as an indication. This can reveal respiratory alkalosis due to inadequate oxygenation regarding to the occluded pulmonary vasculature. You may see a lower than normal partial pressure of oxygen, lower than normal partial pressure of carbon dioxide, and pH may be higher than normal with or without compensation, or within normal range depending on whether shortness of breath or hyperventilation has been prolonged.
We will then anticipate a D-dimer test to be conducted. A D-dimer blood test measures degraded fibrinogen, which is elevated when the clots are present. It is highly sensitive but not specific to confirm DVT or pulmonary embolism. A positive D-dimer score, which is a value greater than 0.5, would indicate further testing. The next test to confirm pulmonary embolism is a computed tomography pulmonary angiogram, CTPA. This involves injection of a radiocontrast medium which travels to the pulmonary arteries and reveals filling deficits in the veins adjacent to the embolism.
Additionally, because pulmonary embolisms originate from a DVT, an ultrasonography may be conducted to assess for a thrombi within the lower limbs. Now, moving forward to our potential treatments and interventions. We will begin by promoting oxygenation by elevating the height of the bed to a high Fowler's position to promote lung expansion, and administer oxygen if there is a decline in oxygen saturation. We can anticipate to administer anticoagulation medications such as low molecular weight heparin, warfarin, or dabigatran, along with thrombolytic medications such as alteplase. Anticoagulants are used to prevent further clot formation and embolization, whereas thrombolytic medications are used to dissolve blood clots.
Next, we will continue to monitor the patient's vital signs, blood work in relation to coagulants such as PTT, INR, and PT, as well as ABGs to ensure all are within normal range. We want to provide patient education on the importance of adhering to medication regimen and ambulation to prevent future DVTs from occurring.
On a side note, if a high-risk DVT is present, surgical interventions may be conducted to protect against life-threatening pulmonary embolisms from occurring. For example, an open venous thrombectomy. This is where an incision is made directly into the vein for removal of the thrombus. Another procedure that can be done is called an inferior vena cava interruption. This is where a filter device is inserted through the femoral or right internal jugular veins. The device then opens up and catches the emboli from advancing further.
Now, moving into interprofessional collaboration, we want to consult with the healthcare provider on our assessment findings. This is where further interventions, such as labs and medications, are ordered. We want to consult with pharmacy for medication education and reconciliation. This will promote adherence to the medication regimen.
And lastly, we would consult with physical therapy or occupational therapy to aid in finding an appropriate ambulation activity to prevent venous stasis, all of which will reduce the risk of a DVT and pulmonary embolism in the future. Now, with our treatment, interventions, and interprofessional collaboration, we would expect our patient to have improved gas exchange, as evidenced by vital signs within normal range and respirations regular and unlabored, absence of pain or reduced pain, labs within normal ranges, and lastly for the patient to show an understanding of how to prevent a DVT in the future via a teach-back method. And that concludes our presentation today. Thank you all for watching.